name is Kjell Gunnar Gundersen. I'm an ophthalmologist, been trained in Norway, and we started a surgical unit as far back as in '97. And then we moved to this premises 3 years ago, almost 3 years ago, which has been brought more enthusiasm into the clinical work, because it's so nice to have good premises for the surgical team and also for the rest of the team. We do specialize in cataract and refractive surgery, and has done so since the start of the century. And we do perform approximately 2,000 surgeries a year with a staff of 15 people. Our patients are mostly paid by the public sector, but we also have around 30 to 40% private paying patients coming to the clinic. What I enjoy the most is meeting people, listening to the stories, which might give me a challenge, and then try to fulfill their wishes surgically. In most cases, this is cataract patients at the age of around 70 with different lifestyles, and we see more and more active elderly people, and this demands us to be more creative in our surgery and tailor-made the surgical treatment for each and every patient. Join me as I discuss astigmatism and the use of toric lenses, followed by a live Q&A. In our clinic, it's now standard. We have changed completely our approach to astigmatism treatment over the last, in the last 3-4 years. Let's give you an example. If you have an astigmatism and you go to your optometrist, no one would not choose to give you a correction for that astigmatism wearing glasses. And the same goes actually for surgery as well. If you have a pre-existing astigmatism, you have a chance in a lifetime to correct that with using the surgical options that you have today with a very high accuracy. So I would say that not using that opportunity is, you really miss the target. And we do have the tools to do so now with a high degree of accuracy for the individual patient. When you, let's say, sell toric solution to the patients, ahead of doing so, I try to interview them and make my impression of what kind of lives they are living. Are they golfers? Are they skiers? Do they have specific interests? And of course, being able to more or less guarantee emmetropia, that they see well at distance without any kind of visual aid, is a perfect way. If you're a golfer, for instance, you will immediately know the benefit of being able to see the ball all the way to the 18th hole. And the same goes for any other physical activity outside. I'm talking to my colleagues more or less all the time to tell them that once you have cracked the code and you have used your competence to understand how important toric lenses are, the rest is actually very easy. From my point of view, stability of the lens which are implanting is crucial, because you want to implant this lens in the correct axis, and if by chance this axis is then changed postoperatively, you will lose effect of that surgical option from the very beginning. So stability of the surgical or the lens being implanted is important, and in order to reach that goal, to have it in the exact axis and stay there, then you need tools in order to guide you to the correct axis. The variant system allows you to do preoperative measurements ahead of surgery with a high degree of accuracy. So you know ahead of surgery which patients are going to profit from toric surgery, from toric lenses being implanted, and who's not. But the variant system, although there is a lot of patients that doesn't need toric lenses, with the variant system you have access to their topographic information, and you can tailor-made each and every surgery, whether it's a toric lens or not. You use the same system. So from my point of view, if a good instrument being taken into a clinic is an instrument that fits in and are being used in almost every case. And that is how we treat our patients with variant system today. I would say the Barrett is a very nice formula to work with, because it takes the posterior surface of the cornea into consideration. It doesn't measure it, but it takes it into consideration and reduces variability in the post-op refractive result that you gain. On the other hand, it's practical, it's time effective. The best option would be to have individual measurements of each and every, and use topographic information from every patient for that particular treatment. But that is time consuming at present, and I think Barrett is a nice compromise between a 100% belief in individual accuracy and how to run a practical surgical activity. There are some key points in order to have a success story with toric lenses, and patient flow is probably one of the most important one, because the lack of time is always critical in a clinic. The way we do it is I have 5 skilled optometrists which are taking these patients preoperatively and do the pre-op examinations, and we do variant pre-op examinations in almost every single case. I would probably say in 98% of the cases we do have variant preoperative examinations. From the preoperative planning station we can export all the information into the surgical room. So while sitting with the patient, I can import all the information I need in order to choose the correct lens and place it into the correct axis during surgery. So I would say when we have this information, the actual surgical extra time is probably less than 30 seconds per patient. Historically, I think a lot of the colleagues didn't want to use toric lenses because the whole marking was cumbersome. It was time consuming and you could make errors. With having the variant system where you electronically have access to the correct axis and you can see it on the screen live, you don't have to do any marks. If the video acquisition is good, then you have access to all the topographic information that you need for the surgery without doing anything else than think. So that makes the whole procedure much more effective and less time consuming. Let's go back to the manual marking again, because I think that is the main threshold for most of the colleagues. They think, and it is more time consuming, and of course if it's a 2-step operation or a 3-step operation, you can make errors in each and every step. At the end of the day, they are going to affect your surgical results. Using a standardized electronic system which takes care of let's say the cyclotorsion, so you image the patient in a sitting position, then you have access to the same information when patients are lying down on the surgical table. You can adjust for that, and you know that you're working in the right axis in each and every patient. And at the end of the day, that makes the post-operative results better and less variable. When we have the post-operative controls, we can refract the patients and then go back to the variant to recalculate whether we reach that kind of accuracy that we wanted from the very beginning. So we can use the variant system in order to improve our results post-operatively in a cohort of, say, the last 50 or the last 100 patients, and then have a system which can be improved all the time. So a continuously working quality system of quality control is imminent in order to gain accuracy over time, to the benefit for our patients.